I'm happy you're already here. So, atong topic for today is heart as a pump. Wala maging the chapters in yung libro. So, and then this will cover cardiac cycle, heart sounds, cardiac murmurs, and the regulation of heart pumping. Kanina, anis yung libro. Although, sige lang, I'll try as much as possible nga magkasinabot ta. But before we go to the actual topic, kanang mag-review sa ako ha, kay very important nga you understand. Okay, so this is the heart, right? So this is the right side and this is the left side. And then, you know that this is the left atrium, left atrium, left ventricle, right atrium, right ventricle. So, ang valves, you have two semilunar valves. You have the aortic valve, this one. This is the aortic valve. So, it is between the aorta and the left ventricle. And then you have this another semilunar valve, the pulmonary valve, which is between the right ventricle and the pulmonary trunk, but the discussion will be pulmonary artery. But strictly speaking, you call this a pulmonary trunk, but we'll just call that a pulmonary artery kaya man visually isulti sa mga authors. And then the AV valves, which are between the atria and the ventricles, you have also two. You have the tricuspid valve, which is between the right atrium and the right ventricle. That's the tricuspid valve. And then you have this mitral valve between the left ventricle and the left atrium. Now, opening and closing of valves, very important, no? Diba? I said it is due to difference in pressures. So, this mitral valve will open if the pressure in the atrium is greater than ventricular pressure. So, tanawa lang position sa valve, murag nagpadung dire. So, it will open if pressure in the left atrium is greater than the pressure in the left ventricle. Ma-close ni siya if ventricular pressure is greater than atrial pressure. Unya, diripod sa aortic valve, yes, this will open if ventricular pressure is greater than aortic pressure. So, remember, if ventricular pressure is greater than aortic pressure, then this will open. If aortic pressure is greater than ventricular pressure, this will close. Okay. Clear na na? Oh, on the other side, the same is true. The pulmonary valve will open if ventricular pressure is greater than pulmonary artery pressure. It will close if pulmonary artery pressure is greater than your right ventricular pressure. And then this tricuspid valve will close if ventricular pressure is greater than atrial pressure, and it will open if atrial pressure is greater than ventricular pressure. So that's important for our discussion for this morning. Okay. Then another thing, I also want to review the cardiac conduction system. So the impulse, the action potential, another term for potential impulse, will start at the SA node. And we have discussed why this is the pacemaker of the heart. And so it starts here and then spreads radially to the atria, and more so for the internodal tracts, faster there. And then for the left atria also to the atrium to be depolarized early so that they will be synchronized. There is the so-called Bachmann's bundle, which is the interatrial tract. Okay, so all impulses will gather or will have to pass through the AV node. No impulse will pass directly to the ventricles. So all of the impulses, those from the atrial cells, those from the internodal tracts, will have to pass through the AV node. And that is important because in the AV node, the impulse is delayed. it's important to delay the impulse so that the ventricular depolarization will not occur at about the same time that the atrial depolarization occurs, because we do not want the atria and the ventricles to contract at exactly the same time. So we have to delay so that depolarization of the ventricle will be delayed. All right, so from the AV node, it will have to pass through. Okay, this is now the bundle of hairs, but when it passes through the cardiac skeleton, it is also delayed. So there is an additional delay there. But once it is out of the cardiac skeleton, then the impulse will travel very fast, so that the ventricles are depolarized almost simultaneously. So, and then we remember that the left bundle branch, the impulse will travel a little faster than in the right, so that the depolarization of the interventricular septum will be from left to right. Okay. And then the impulse will now there, and then it travels upwards to depolarize the ventricle. Gadget lang ha. Ay, excuse me. Nasave na ko, previous. Okay. And then, so, baka distracted ko. Jen, sabak kay mo day. Close the door, please. Okay, so the depolarization of the ventricular walls will occur via the terminal Purkinje network. The terminal Purkinje network has the fastest rate of impulse conduction, and it will even penetrate the ventricular wall, okay, and will end on the ventricular myocardial cells. So depolarization is from endocardium to epicardium, and then the last to be depolarized will be your posterior-basal portion of your left ventricle, the upper interventricular septum, and then the pulmonary conus. Okay, so that is our how the heart is being depolarized. Now remember that depolarization precedes contraction. Okay, now these are the ventricular volumes, the ones that, my first part of my handout is definition of terms. Okay, so let's take, for example, end diastolic volume. All right, so let's say this is the ventricle, all right, because our definitions is in terms of the ventricle. Okay, so this is the ventricle, okay, and the amount of blood present in the ventricle just prior to systole or just prior to contraction is what you call the end diastolic volume. So this is the end diastolic volume. This is the amount of blood just before the ventricle will contract, and you call that the end diastolic volume. And then when the ventricle contracts, okay, so it will eject this amount. So it will eject this amount, and you call that amount that is being ejected as the stroke volume. Okay, so end diastolic volume, then you let the heart contract, and it will eject about 50 to 60% of the end diastolic volume will be your stroke volume. So that is now out of the ventricle, and what will be left behind will be your end systolic volume. Naturally, end systolic, so end systolic volume. Okay, so this will be your end systolic volume. But if you increase the force of contraction of the heart, if you increase it, the heart will still be able to eject an additional amount. So this is the one. The heart is still able to eject an additional amount, which we call the systolic reserve volume. Reserve lang na siya because like now you're sitting down, you are just expelling this amount. But let's say, for example, you run around the campus and you need more blood, so you will expel also reserve, the reserve volume. Okay, systolic reserve volume will also expel that. But once it is expelled, it becomes part of the stroke volume. You understand? Once this is expelled, this is reserved. But once it is expelled, once it is ejected out of the ventricle, then you call that already, it's already now a stroke volume. You understand? Okay. And what will be left behind will be your residual volume. So this is your residual volume. It will always be there in your heart. It will not be ejected. No matter how strong your ejection, no matter how strong your ventricular contraction, this will stay behind. By the way, do you see my arrow?
Yes, Doc.
Okay. Kahit araw-araw lang ko niya, umuka kita. Okay, so you understand now, once this is ejected, it becomes part of the stroke volume. Okay. Now, this one up here is the, what? Diastolic reserve volume. What do we mean by that? Now, your heart, okay, normally, with normal activity, you just have this end diastolic volume. But your heart can still accommodate an additional amount. Like when you are running, okay, so you are expelling, you have already used this, and then the heart can also still accommodate an additional amount. So this is a potential volume. So it is a potential volume, and it is only used if we need more blood to enter our hearts. So, and of course, if you increase your venous return, by venous return, we mean the blood that is going back to the heart. Okay. So if you increase the venous return and you make use of this potential volume, you make use of this potential volume, and then you expel that, then again, it becomes part of the stroke volume. Okay, anything that will be ejected, your reserve, systolic reserve, and your diastolic reserve, once it is ejected, it becomes part of your stroke volume. So your stroke volume will be much increased. Is that clear? Any questions so far? None. Okay. Now, cardiac output is defined as what? The total output per unit time, usually per minute. So total output. So per beat, you have your stroke volume. Per beat, every time your heart beats, you have your stroke volume. So if we want to know how much is your output per minute, that will now be your cardiac output. So you will just multiply your stroke volume times your heart rate. How many beats how many beats do you have in 1 minute? For example, your stroke volume is 70, then your heart rate is also 70, then how much will that be? That will be 4,900 ml, or your 4.9 liter. Okay, so that will be your cardiac output. So cardiac output is equal to stroke volume times heart rate. Okay, is that clear now? Okay, another thing to remember is that before we go to the cardiac cycle, another thing to remember is that blood flows from an area of greater pressure to an area of lesser pressure. That's very basic, right? Okay, so any questions before we now go to the cardiac cycle? Wala. Understood na so far, no? So far? Okay, so we now proceed. Okay, don't let this scare you. It's not really scary. It looks scary at first. Now, this diagram, I took this from your Vander, oh, not Vander, from your Guyton, but I made some modifications. For example, this one, this line is not present in your Guyton, but I placed that there because I divided this phase into the rapid and the reduced. And then another thing, this one also is not found in your Guyton. And most books of physiology, they do not include this. But there was one book, I cannot remember where I got it, that it included this one. And I think it's very useful later. So this is, let me introduce my diagram. Okay, you have this in, I gave this to you in my slides. So let's just introduce it. Here you have pressures, right? And this one is also pressures of the right side. Okay, this will be your lungs also. And then this will be of your left side. Okay, and then this blue one is your volume of the left ventricle. Okay, and then you have the ECG here, ECG tracing. And I told you last time, I just want you to know that the QRS, this is the QRS, this is ventricular depolarization. And then this is the T wave, which is your ventricular repolarization. Then the P wave, which is your atrial depolarization, followed immediately by your ventricular depolarization. Okay. The heart sounds, we will talk about this later. Let's just focus on this one. Now, most books, they will just have this diagram and then just discuss what happens, that what happens in the left side will also happen in the right side. But I would prefer that we talk about the two sides because it will help you, I think. So I hope it will not discourage you. It's not really difficult to understand. If you just talk about each phase slowly. Okay, so we have here this red line. Okay, let me, this straight red line, okay, will represents what? Ventricular pressure. Because when we talk about the cardiac cycle, we will be talking about the changes in the pressure in the ventricles, in the atria, and in the large arteries. You have your aorta in the left side and your pulmonary artery or pulmonary trunk in the right side. So this is your right side, your pulmonary circulation. This one, your systemic circulation. Okay. Now, you will notice that the pressures in the right is very much lower than the pressures in the left. Okay, because of course the lungs, they're small, while the other is giving blood to the rest of the body. So syempre, the pressures in the right side will be lesser. Okay. So the red line, the same is true. No? The red line represents this one, left ventricular pressure, while the red line here, of course, represents right ventricular pressure. Okay. Now the green, can you appreciate the green color? Okay. The green dotted line is your aortic pressure. And what is the equivalent at the right side? This will be again now green dotted line represents your pulmonary artery pressure. Okay. So they are the counterparts. And then this red line straight here, of course, will be right ventricular pressure, the red line, okay, right ventricular pressure. Then the black dotted line, this one, is what? Left atrial pressure, while here, the black dotted line here, the black dotted line here represents right atrial pressure. Okay, this one, as I said, this represents ventricular volume. Okay, Now, nasod na sa inyong ulo? Huh? Okay. And then, the cardiac cycle is divided into two major periods. Your ventricular, now the periods are in terms of the events in the ventricles, but we will be talking about what's happening in the atria and in the blood vessels. But the timing will be in terms of the events of the ventricles. Okay, so you have two major divisions. You have your systole, it is pronounced systole, and diastole. So systole is the period of ventricular contraction and ejection of blood. Okay, so diastole is ventricular relaxation and filling of blood in the ventricles. So these two, systole and diastole, all are alternating. So systole followed immediately by diastole, then systole, then diastole. So they come systole and diastole. Okay, they alternate. Okay, now here I use this diagram because I want to start with systole and then followed by diastole and then go again to systole. Now in some books they have different phrasing. I mean, but the some would start with atrial depolarization and then, but I think that is confusing. So I will just start with systole, that's ventricular contraction, and diastole, which is ventricular relaxation. Now, each of these two major periods, systole and diastole, is also composed of phases, which I've called phases, although Guyton calls it periods. So it's the same, no? So you notice here that the different phases of the cycle, this is time, these lines represent time. Milliseconds, okay, this represents time, and you know that they are not equal. Okay, so we start with systole. Okay, that's ventricular contraction. So we start here, and if you notice, you have, it is preceded by ventricular depolarization. And you look at your ECG tracing here. So the onset, this line here, marks the onset of systole, and it occurs at about the peak of your QRS complex. So depolarization of the ventricle, okay, and that will now start now of the contraction of the ventricle. Okay. Okay. So here, this is the beginning of your first phase, which we call the, what's the first phase? Isovolumetric contraction. So by the term itself, so the first phase is isovolumetric contraction. So isovolumetric, meaning there is no change in volume. There is contraction, there is no change in the volume, isovolume, and in the length muscles. So it's called isovolumetric contraction. So we now have the onset of ventricular contraction, and immediately the minute when the ventricles contract, of course, pressure there will increase, right? The minute ventricular pressure exceeds atrial pressure, what happens to our valves? Well, what happens to our mitral valve? So we are talking here on the right side. So the minute left ventricular pressure is greater than left atrial pressure, what happens to the mitral valve? Will it open or close?
Close, Doc.
Close, very good. So now,
Close.
yes, close, very good, thank you. So now, ventricular pressure, so immediately mo contract ng heart ang ventricle, and then pressure now will immediately increase, and then immediately it becomes greater than atrial pressure. And so therefore, when that happens, okay, here, when that happens, the AV valve will close. The mitral, MC there is mitral closure. Okay, so the minute that is exceeded, the atrial pressure, then that will close. So now at this time, all the valves are closed. The semilunar valves and the AV valves are closed. So now the ventricles are contracting, but there is no release of blood, right? Because the valves are closed. So you are the ventricle is contracting against contained blood. Whatever blood was there, there's no change in the amount of blood. The amount of blood present there at the onset of ventricular contraction is what? How did we define it? Then look at your definitions, diba? And diastolic volume, because diastole has just finished. We are now in systole. So this will be, this blood that is contained here is your end diastolic volume. We have defined that as the quantity of blood in the ventricle just before systole. Okay, so the amount of blood present in the ventricle just before systole, okay, before the contraction of the ventricle, is your end diastolic volume. So it contains much blood, and then it is contracting, but there is no release of blood because all the valves are closed. Okay, but why is there? You understand now? So when when the ventricle is contracting, of course, ventricular pressure will immediately increase, right? So ventricular pressure will rise up rapidly. The same is true with the left side, but pressures in the left side is very low. That's why few authors will picture this. But I will show the importance of this one later. So anyway, so ventricular pressure will immediately rise rapidly. Okay. And then notice now, so there is increase in ventricular pressure. What about in the atrial pressure? So you have the C wave here. What is that C wave? All right. This is because, so this is, it seems like the atrial pressure is also increased, right? Why? Because when the ventricles will contract, when it closes now the valves, the AV valves, the valve is now closed, it will then bulge towards the atrium, making this C wave. Okay, so it's a bulging of the ventricle of the valve, diba? But the valve is prevented from eversion. You understand eversion is? So it will prevent the valve from eversion because of what structures? This came up in the exam. Contraction, the exam. Okay, contraction of this structure prevent the eversion of the AV valve to the atrium. And the choices in my exam was, you can choose between papillary muscle and chordae tendineae or just papillary muscles. Now remember, chordae tendineae does not contract because this is fibrous tissue. So the answer there was only papillary muscles. Okay? Murag tricky na, pero I just wanted to make sure you know your histology. Wrong mo adto. O, na-check mo.
Nay both ato dok ba, both papillary muscles and chordae tendineae imong gibutang. Both.
Pero remember that chordae tendineae does not contract. Na imong contraction of. So it does not contract. Fibrous tissue ba siya? So it was only the papillary muscles that contracted. Diba?
Thank you, Doc.
Okay. So here now, so the AV valve, the mitral is prevented from eversion because of the contraction of the papillary muscles. But then it bulged. So it gave this C wave in the atrial curve, but it will just go down. Okay, it will just go down. And then, okay, so now let's go back to ventricular pressure. It's increased. The minute ventricular pressure exceeds aortic pressure, so this is our aorta, right? So the minute it exceeds aortic pressure, what happens? Hindi naman siya sa aortic pressure. What valve will be affected? The minute ventricular pressure is greater than aortic pressure, what valve will open? This is your valve.
Aortic
Here.
valve.
Oh, the aortic valve will open, di ba? Yun ta, when left ventricular pressure is greater than aortic pressure, then aortic valve will open. Di ba? Di ba? Opening and closing, di ba? That's why I tried to recall. So the minute ang pressure sa ventricle is greater than the aortic pressure, mo-open gina ang imong aortic valve. Right? Huh? Let it sink. Ang
Yes, Doc.
aortic, ang imong ventricular pressure is now, di ba, it's increasing rapidly. It's increasing rapidly, kind of contraction, niya, closed ang valves. Pero, the minute greater na siya sa aortic pressure, then your aortic valve will open. Kasabot? Ka-imagine mo?
Yes, Doc.
Okay, so that will now mark the end of your isovolumetric contraction. Di na gina sa iso kay na may release of blood. So now, the minute, wow, okay, the minute this will now open, what will happen? Blood will be ejected, right? So the minute aortic valve opens, that will mark the end of your isovolumetric phase and the onset of your rapid ejection phase. So there is rapid outflow of blood from the ventricle. Right? Clear ba? Paminaw lang yung maayo ha? Sige, sige. Diba, ni-contract siya, isovolumetric contraction. Of course, it is contracting and yeah, close ang tanang valve, so it is contracting but no change in the volume of the ventricle. And the length of the muscles will change. And then, of course, there will come a time that ventricular pressure now becomes greater than aortic pressure. And when that, diba, closing and opening of valves depends on pressure gradient, pressure difference. So the minute ventricular pressure is greater than atrial pressure, than aortic pressure, so the minute ventricular pressure is greater than aortic pressure, then of course the aortic valve will open. Okay, the same is true here. The pulmonary valve will open. The minute right ventricular pressure becomes greater than pulmonary artery pressure, then the pulmonary valve will open. Okay, so let's hear. And that, when the minute that opens, that is now the end of your isovolumetric. Then again, the isovolumetric. Okay, di na may change in volume. Okay, so that will mark the end of your isovolumetric phase of your systole, of your cardiac cycle, and the beginning of the next phase, which is rapid ejection phase. Okay. So rapidly eject ang blood. So what happens? The pressure in the ventricle is still greater than aortic pressure, as shown here, no? Ventricular pressure is still greater than aortic pressure. So blood will flow to the aorta. Diba? Blood flows from greater pressure to lesser pressure. Ventricular pressure is still greater than aortic pressure, so blood will flow to the aorta. And of course, the blood in the aorta will not stay in the aorta. It must flow to the periphery, diba? From aorta to large arteries to smaller arteries until it goes to the circulation, it goes to the tissues. Okay, so that will be called the runoff. So the runoff. So Aortic pressure is also increased because blood is already flowing to the aorta. Ventricular pressure is still greater than aortic pressure, so blood flows to the aorta. All right. Now, blood flows to the aorta, and from the aorta, blood will flow to the periphery. Okay. And this rapid ejection phase will end when the flow to the aorta is in equilibrium to the flow from the aorta to the periphery. So now aortic pressure is at its peak. It is now here that there is equilibrium for the blood that's flowing to the aorta and the blood that is flowing out of the aorta. So that's your aortic pressure. It has become peaked. And what about ventricular pressure? It has also reached its peak. Okay, so at this point, this will now divide. That's why I put at because some authors divide this into two. The two will be ejection phase, as shown in your Guyton, but we have divided that into the rapid phase and the slow phase, or the reduced ejection phase. Now, the diagram is not very good in its timing because supposedly this is just 1/3, and that is not 1/3, it's almost 1/2, no? But my drawing is already there, so I put my drawing there. So, so this rapid ejection, so 1/3 of the blood in the ventricle will be ejected at this time. And the 2/3 will be at the reduced ejection phase. Now let us look at the volume in the ventricle. See, the volume has decreased rapidly. The volume okay, look at the volume. So the volume here, there was no change. And then with the rapid ejection, there was a marked decrease in the volume in the ventricle. Okay, because it was already ejected. So the minute the pressures in the ventricle and in the aorta are at their peaks, that will now be the end of rapid ejection phase and the beginning of the reduced ejection phase. Okay. Any questions so far? Am I going too fast? Question.
Doc, ay mag-clarify lang ko, Doc, na wala mong question. Ang kining kuan, Doc, mahuman ang isovolumetric contraction phase if mag-start na og open ang aortic valve, Doc?
Yes, yes. The minute aortic valve opens, that will now be the end of your isovolumetric phase and the beginning of the rapid ejection phase. Kaya di ba ma-ejected namang blood? O ika-eject sa blood, dili na gina isovolumetric, the volume in the ventricle now will change, right? Oh, it has changed. Okay. So,
Okay.
kanang end sa usa ka phase is the beginning of the next phase. Okay ba?
Okay,
Understood
Doc,
na?
thank
So, the end of this phase, the end of the isovolumetric phase is now the beginning of your rapid ejection phase. Walay space. The end of one is the beginning of the next. Okay. Okay na?
Yes,
Alright.
Doc. Thank you.
Okay. So, rapid ejection ends when the flow to the aorta is equal to the flow to the periphery. And look at that is now the peak of your aortic pressure. And the same is true with ventricular pressure. Ventricular pressure, that is also its peak. And that is the end of your rapid ejection phase and the beginning of your reduced ejection phase. As I said, even in your notes, that 1/3 of the ejection will occur in the rapid, 2/3 in the reduced ejection. And then we looked at the ventricular volume it rapidly decreased, right? So the volume rapidly decreased. Okay, now, so that will be the end. But look, let us look at the pressure in the atria. Okay, the pressure in the atria is slowly increasing, very slowly increasing. Why? At this time, during ventricular contraction and the AV valves are closed, what is happening in the atrium? The AV valve, the mitral valve is closed. And what's happening in the atrium? Why is there a very slow increase in pressure? Remember, this was just due to the bulging, right? And so there is very slight increase in the pressure in the atrium, in the left atrium, okay? Why? What's happening? Okay, all the time that the ventricle was contracting, what was happening in the atrium?
Atrial feeling, Doc.
Okay, the atrium naghinay-hinay pud siya og receive og blood from the veins, from the pulmonary veins, no? Kung naata sa left side, ang musod sa left atrium will be the blood coming from the lungs, right? So remember, you have 4 pulmonary veins draining into the left atrium. So it is receiving blood from the lungs. So maghinay-hinay siya na siya increase. The pressures in the atrium di na siya mapareha sa ventricle. Kung ano lagi na siya, mubo lang gina siya pressures ang imong atrium. Okay. So now we are at the end of your rapid ejection and the beginning of the slow or reduced ejection phase. Okay. Now, is there still ejection in the reduced ejection phase? Or by the term, there is ejection. But you will notice that aortic pressure is slightly greater. Oh, aortic pressure now is greater than ventricular pressure. Ventricular pressure is lower here, but still there was ejection of blood. Diba, we said that blood will flow from greater pressure to lesser pressure. But here, ventricular pressure is already lower than the aortic pressure, and yet blood was flowing from the ventricle to the aorta. Why is that? That's defying physics, right? Because we said blood flows from an area of greater pressure to an area of lesser pressure. We now here have a condition wherein ventricular pressure is less than aortic pressure, and yet ejection occurs. Why? Anybody?
Cylindrical form sa aorta, Doc.
Form sa aorta?
Cylindrical lang.
Another. Kuan, kanang, remember your physics. Have you taken
Unsa ganito,
physics?
Doc? Ang question.
Ang question is, diba, niingon ko at the start na blood flows from greater pressure to lesser pressure. So there is a rapid ejection, ventricular pressure, diba, ibabaw siya. Ventricular pressure was greater than aortic pressure. Naturally, blood flow from the ventricle to the top. In this reduced less than aortic pressure, and yet flow still comes from the aorta. So wala na siya mo follow sa akong giingon na blood flows from greater to lesser pressure, because here ventricular pressure is lower than aortic pressure, and yet there was still ejection of blood. Ano man? Because as you can see here, sa volume sa ventricle, nag-decrease pa rin. Sa ito pa, there was additional ejection of blood out of the ventricle. So nga naman, blood, when ventricular pressure now is less than sagot mo sa kong question. Oh, what is the reason? Physics. It is still physics. Physics ang nag-ingon nga blood flows from greater pressure to lesser pressure. Physics lang po ang mo explain, ani. Why there is still ejection even if ventricular pressure is now lower than aortic pressure.
Doc,
Okay, sa man to
Doc,
Dok,
It is due to
putol-putol po kayo, Dok.
putol-putol ka, Doc.
ano na putol. Hello, ano saan nagsugod? Bagula?
Kanina, Dok. Kanina pa.
Dok.
Itong rapid.
Murag in the middle sa imong question, Doc. Naputol-putol.
Pagsugod, kung question dito, ko pa-questionan ninyo.
Dato dapat makarapid, Dok.
Putol
Putol na ka, Dok.
Pwede ba?
Ito, very good. Oh, time pa. Karon ba na ko nagputol-putol?
Wala na,
Karon.
Dok.
Doc.
Wala na, Dok.
Oh, sige.
Dok, putol-putol.
Asa mo kumabalik?
Doc, nibalik na po.
Kumabalik. Hello, so many. Oy. Ang ako ni internet. Ba supposedly may internet. Karon lang gid ni nahitabo ba?
Ganahan sila mo.
Internet is- Ganahan tingin sila mo answer. Ganahan sila mo sa kong lecture. Tayo pa manawag sa ko sa kong anak. Kung na ba siya mabuhat, ani. Kay actually, this is the first time nag-problem ni ani. Murag di malas lang gid ko karong buntagan. Nak, internet is there. Ang internet na problema ko. Napuputol ko. Ay, ang internet is mana. Paano sa nimo? Ay, tingali ka ng internet sa ay.
Pila na kaya minag-internet? Ang kaya ba mga naputol-putol ka?
Sila. Reklamo sila.
Try daw. Okay na ba?
Saman, okay na? Hello?
Yes, Doc.
Hello?
Yes,
Okay na,
Okay
Dok.
na? Oo, sige, sige. Asa mo kumabalik? Tingali ka ng internet. Pero usually mag-internet ang nagdungan. Ha? Reduce ejection? Out. Asa kumabalik? Hello?
Sa question, Doc. Itong na physics, Doc.
Okay. So, nga sa reduced ejection, ventricular pressure now is less than aortic pressure. So, supposedly, dili na gid maka-eject og blood kay ventricular pressure is now less than aortic pressure, right? Kaningon man tangaw, blood flows from greater to lesser pressure, right? But now, ventricular pressure is less than aortic pressure, so supposedly, there is no more ejection of blood to the aorta because ventricular pressure is now less than aortic pressure. But there is still ejection. There is still ejection. That's why reduced ejection. So naagya po ejection as can be shown from our volume curve. Nag-decrease pag yun, di ba? Nag-decrease pag yun ang volume. So what is the explanation? Physics and explanation. What? Oh, now yan is in your notes. Okay. The reason
Sa
is
imong ano, Doc, kay momentum sa imong
Inertia.
hands, Doc.
yes, okay, because of momentum. Di ba ka nang mag-drive ta og car? Kasi man doon car. I-driving mo, yan yung stop ang engine, di ba mudagan pa rin? Di ba? Mudagan gihapon for a time. Oh, sige, basta kayo mag-drive, sulirain ninyo, mag-drive mo car, then you stop the engine. That will still run for a few distance. Okay, so that is momentum or your inertia in motion. Okay, so there is still ejection. And then, no, aortic pressure is greater than ventricular pressure. So towards the end of this phase, the blood in the aorta will tend to flow back, it flows back to the ventricle, and the going back of the blood from the aorta to the ventricle will close the what? Will close the aortic valve. Okay, so mo close ang aortic valve. So this now marks the end of your reduced ejection phase and the beginning of your isovolumetric relaxation phase. So mo close na. Your aortic valve will close now. Okay? Close na siya now. So now once again, all the valves are closed. Diba? Kay closed pa dire. Remember? Nga, closed dire ang imong AV valve. Ang imong mitral valve is closed here. And now your aortic valve is also closed here. So therefore, all the valves are closed during this next phase, which is your isovolumetric relaxation phase. Muna equivalent sa imong isovolumetric contraction. This one is isovolumetric relaxation. So nag-start na ang pag-relax sa heart. Okay, so nag-relax ang heart, all the valves are closed. Naturally, your ventricular pressure is rapidly also decreasing. Diba? O, rapid po ang pag-decrease. And then, you notice the ventricular curve, the volume. Okay, there is no more change in volume. That's why it's isovolumetric relaxation phase. All the valves are closed. Ventricular pressure is rapidly decreasing. And your atrial pressure is increasing. And you have the V wave there. So it is now markedly increased. I mean, it's not markedly because atrial pressure is not really very high, but it is at its peak at this time. Okay. And so the ventricles are contracting with all the valves closed, and it's contracting with that amount of blood that was left behind after ejection. What do you call that blood present in the ventricle? Di ba, na-ejection ta diri. Ejection ta. So, blood was ejected out of the ventricle. Yan, nag-close na din mga valves. So, isovolumetric. So, what do you call this blood here present in the ventricle now? You find that out, huh?
And systolic volume.
Okay, very good. And systolic, naman ako systole. Ang systole is already through. So now we are now in diastole. So diastole therefore starts with the onset of isovolumetric relaxation. Diba ang diastole is relaxation, okay? And systole is contraction, and you have relaxation now. So you have isovolumetric relaxation phase of the cardiac cycle. No change in volume, but there is blood in the ventricle, which you call the end systolic volume because humana ang systole.
Yes, doc. Yes, doc.
Good. Any questions? All right. And this phase will end. You have ventricular pressure is markedly decreasing until atrial pressure now is greater than ventricular pressure. So what happens to our mitral valve? Atrial pressure now is greater. Okay, atrial pressure is greater than ventricular pressure. So your mitral valve will open. And that will now mark the end of the isovolumetric relaxation and the beginning of the rapid, what? Rapid
Feeling phase.
phase.
Rapid feeling.
So, diba? Logical kaayo. So, dili lisod pag memorize. You can explain this without your notes. You can logical kaayo. Very logical.
Dok, putol-putol, Dok.
Oh, yeah. Noon sa naman ko.
Dok, putol-putol, Dok.
Okay.
Putol-putol gihapon, Dok.
Okay. Ano yung spoon, ang position, maybe it's a position of the kadjat lang ha. Akong hiwi on ang akong Okay, saman. Arang-arang na?
Yes, Doc.
Okay. So, dili na ta sa opening of the mitral valve. So, unsa may tabo kang mag-open ang mitral valve? So, MO is mitral opening. So, what happens now? If the mitral valve is now open, what happens?
Na ventricular feeling.
Okay, and you will notice now that atrial pressure is now greater than although slightly greater lang yun ang iyang atrial pressure, but still, it's enough to push blood into the ventricles, no? Greater pressure in the atria than in the ventricle, so blood will flow from atrium to ventricle. So, although the pressure difference is less, much less, but still flow occurs. Okay, and the first third is rapid filling phase. Okay, and then you look at the ventricular volume curve. Okay, so it is increased, right? So increase na. And then, as I said, when this phase will end and when is the beginning of the reduced filling, it's very difficult to say. Kaya makaingon dali ka lang, naghinay na siya. Di ba? Isod kay pagsulting, hinay na siya. Unlike the other phases na, murag klaro ring mga na-close good ang valve, na-open ang valve, no. But here, between the rapid filling and the reduced filling, it's very difficult. But anyway, we have put it this way. According to them, it's 1/3 and this is 2/3. Okay, and then you can see now the volume is increased and atrial pressure is still greater than ventricular pressure. Then this is followed by your diastasis, which is your reduced filling. So another term is diastasis. And they say that it is at this phase that the ventricles or the heart is at its most complete rest. I mean, not really complete, yung mamatay na complete rest. The heart is at rest, no? So, kanang rested kayong heart at this time. So now, the ventricles and the atria, ang ventricle ug ang atrium, they are acting as if one vessel lang sila. Because what enters in the atrium will just flow to the ventricle. So, mura lang sila, usa ka vessel. So, blood coming from the pulmonary veins enter the left atrium, then to the ventricle. Okay, and look at the volume of the ventricle. Okay, there is still an additional amount that is placed into the ventricle. Then, aortic pressure is continuing to decrease because flow to the periphery is continuing. Okay, and the pressure, of course, is decreasing. Okay. Now, suddenly, the atrium will contract. And this was preceded by atrial depolarization. Look at the P wave in the ECG. Okay, this precedes atrial contraction. So, suddenly, the resting ventricle is interrupted by atrial contraction. So, there is a slight increase in atrial pressure. And also, because they are acting like one vessel, ventricular pressure, the A wave, which is atrial contraction, is also reflected in the ventricle. So, mura po siya nag-kuan po, nag-A wave po ng ventricle. So, and atrial pressure is still greater than ventricular pressure. And then, so when the atrium will contract, there is an additional amount of blood that will go to the ventricle. So you look at this one. And according to the books, the volume of blood that is added during atrial contraction is about 20% of the cardiac output. So this represents 20% of the end diastolic volume. Okay. And then immediately, atrial contraction is immediately followed by ventricular contraction. So we are back here. Ventricular contraction naman po. Klaro? Kaya may dili.
Dok,
Ha?
mag-ask, Dok.
Pardon?
Mag-ask ko, Dok.
Sige, sige, okay.
Dok, o kanang duha ka din niya, kanang diastasis bitaw, Dok. Then, ay aortic valve closes. At the same time, kaya mag-close ni sila, Dok.
Time pa, may mga kag nag-close niya, wa ko may ni open, closed gina siya. Di ba niwan ko diri nga,
During rapid inflow, Dok, of diastasis, dungan sila
Diastasis.
mag-close, Dok.
Open siya, oh. Mitral valve is open. Kaya saan pag-agi sa blood, kung close siya, open siya all throughout here.
Ay, kanang sa taas, Dok.
And this
Katang
one?
kanang sa right side taas, Dok, kanang aortic valve closes, Dok.
Here it is, at kaning ni as arrow, kani bitaw, kani arrow, ni close siya diri and it remains closed unless I
Ay.
tell you ni open.
Sakto, sakto, Dok.
Oh.
Ah.
Basta gali wa pa mo, wa ko maingon nga open or closed gid siya. So closed gid siya all the time that this is occurring, all the time na nag-filling ang imong ventricles, ha? Nag-filling imong ventricles of blood from the atrium, all the time ang imong aortic valve is closed. All the time closed na siya. Pero pressure is decreasing kay there is flow to the periphery. Now remember nga ang imong aorta is kanang rich na siya ang elastic tissue, di ba sa histology, nag-study na mo aorta sa histology. So nag-study na mo blood vessels sa histo. So ang imong aorta is, wala pa, sige, ang imong aorta rich in elastic tissue. So kanang imong aorta inig-flow sa imong inig-eject og blood gikas ventricle, mo expand na siya. Elastic mo siya, mo expand siya. And then with its elastic recoil, maghinay ko na siya kanaog, maghinay na siya gamay, and pushes blood to the periphery. So muna ni yung blood is pushed to the periphery. So nag-decrease gadi iyang pressure, kay nagkagamay man iyang blood. Right? Kaya ni-agto na good, ni-circulate na dito sa imong circulation. So, but aortic valve remains closed. Kanong sa man siya ni open? Dire siya ni open. Oh, nira ha? So, kani mga arrows, mauni ang points nga sila nag-open, sila nag-close. Pero wa pa gali, kare, wa pang gid ko ni istorya pa nga ni kuan siya ni open. Diri na ta mag-istorya nga ni open. Right? Did I answer your question?
Yes, Dok. Dok, kanang unsa gani causes anang bulging diya sa letter C, Dok?
Ay, ang imong ni contract ang di ba ni contract imong ventricle diri di ba that is isovolumetric contraction, di ba ni systole is ventricular contraction. Pag contract niya, immediately ni close ang imong mitral valve, di ba? O MC, mitral valve closure. So MC, mitral is an AV valve. So, kanimang good, munang AV valve lang ilang gipangalan kay wa man gud sila mo discuss sa right side. So, mitral valve closes here. So, pag close sa mitral valve, syempre, ni-close ang imong blood kay taghan man kaayo. Originally, mura siya mo bulge. Mura siya mo push sa imong blood dito sa imong valve. Imagine mo, ini-contract sa imong ventricle, mo close ang imong AV valve, mo close imong mitral valve, and then, may tendency nga mo bulge usa na siya dito towards the atrium. Para bitaw ng payong nga gihangin. Ka-experience mo anang payong nga gihangin, di ba? Murag mo bali. Mo bali gid sa makabali. Sa dili ka bali. Mo action lang siya bali. Mao sa ni siyang imong C wave, murag mo bulge kadiyot ang imong valve. Unya, mo balik na pud siya, munang imo sang C wave mawa na pud. Kani, mo bulge na pag-bulge imong AV valve, pag-bulge imong mitral valve dito towards your atrium, muna mo bulge siya. Unya, murag there is supposed to be an increase kani gamay gud ang manigamay imong atrial volume. So mo increase gud ang imong pressure. Physics gihapon na siya. So anyway, ni bulge siya, ni cause siya og C wave. Inisod. But then, wala na siya mo bulge, muna ni kanaog na lang po ang imong pressure. O na gini ang pressure niya, slowly increasing until, agay na lagi na makalit. Okay, until you get the V wave nga ni sa kataas na this is the maximum pressure of your atria, of your atrium. And then ang yadang pressure sa imo dayong atrium will now be greater than ventricular pressure mo nang mo-open na po imong mitral valve. So diba, increasing ang pressure sa imong atrium, decreasing ang imong ventricular pressure. There will come a time now that atrial pressure is greater than ventricular pressure. So what happens? Greater ng atrial pressure sa ventricular pressure. Ano sa may maitabo sa atong mitral valve?
Open, Doc.
Open. So, inig-open na niya, syempre, musod na din ang blood from the atrium to the ventricle. Diba? Abdi na good. Yeah, greater na good ang pressure. See? Greater na ang pressure. Although the difference is very slight, but still, atrial pressure is now greater than ventricular pressure. Kaya, ang imong ventricle, diba? Gamay na lang siyang blood. Ang imong atria, daghang egg blood, kaya nag-accumulate ba siya diri? So, pressure in atria is a little greater than ventricular pressure. So now, blood will flow from atrium to ventricle. Hang to diri. So this entire process from the opening of the mitral valve to the end of atrial contraction or to the beginning of the next ventricular contraction, this will be diastole. And that one will be systole. From here to there, look at my, ay, man makita akong arrow. Do you see my arrow in my drawing? Na ako'y arrow diri nga, asagikan ang systole. Anyway, systole is from the onset of isovolumetric contraction to the end of your reduced ejection or to the beginning of isovolumetric relaxation phase. That will be your systole. So systole is from there to there, while diastole is from here to there. Because this is now followed now immediately by, I have the drawing there, the ventricular volume, this one. This one is immediately, o dara akong gidrawing balik ang imong P wave. Okay, and this is now interrupted by your ventricular contraction. Ventricular contraction ka na diri, then closure of your mitral valve. Do you understand?
Yes, Doc.
Any more question? Any more question?
Doc,
Oh, saman.
mag-take note ni sa specific measurements of pressure or volume. Like for example, during the aortic valve opening, 80 mmHg ang iyang pressure. Kinahanglan pa na mo na specific take note.
You should just try to be able to differentiate the changes in pressure. Like for example lang, mutana lang ko, pananglitan. Kung sa may, ano sa man highest ang pressure sa ventricle? Or unsa may mga changes, pananglitan. Try to take note na unsang, i-compare bitaw nimo ang mga pressures between ventricle and aorta, between ventricle and atrium, na unsan ganin ni rapid rise diri, ganin ni rapid decrease, mga changes ba in I'm very concerned about changes in pressure and then what's happening to the valves and changes in the volume here. Volume in the ventricle, because we are concerned here with cardiac filling also. So kinahanglan ba kay babo kanung sana siya ni decrease ang yung volume. Mag-stand lang din mo sa nahitabo. When you study mo no. Tanong mo ano kung diagram niya. Tanong sa mo sa inyong notes, and then as you go to your notes, try to understand what's happening. Ang kanya kung pang yaw-yaw din naagi sa inyong notes. In fact, more gali sa inyong notes, kaya some of the things wala na ako gisulti. Ito na lang mga importante. So, tanawon gid ninyo. Kung may isovolumetric contraction, ma-picture na magdina ninyo nga, nag-contract, so wala close na dyan ang mga valves. Kaya kuan gud siya, close diri, diri pa siya ni close din diri. So, kanida yun, close na gid ang tanang valves, dili na lang po nag-open, di ba? So, inyo gini ma-imagine, try to make a story out of this na, we start to contract ang ventricle. Siyempre, dako naman din yung pressure, ni-close dayon ang valve, ang AV valve, ang mitral valve, i-close dayon. And then, pag close niya, all valves are closed, mo naghihingan siya isovolumetric contraction. By the term, it implies isovolumetric, meaning there's no change in volume and there is no change in the length of the muscle. Sa ato pa, close gid ang tanang valves. Diba? That's why it's isovolumetric. Close ang tanang valves. Unya, it's contracting against a volume, so therefore the pressure will be markedly increased until ventricular pressure becomes greater than aortic pressure. Sige ha, akong i-discuss fast. Okay? And listen carefully. I will go through the cycle again, this time fast na. Okay, kung ano man ni ka ng review naman lang ni. Sige, okay ha? Sige. We have divided the cycle into two major periods. You have systole and diastole. Systole is ventricular, because we said that the cycle is in terms of the events in the ventricle. Okay. But we are going to study what is happening in the other portions, okay? But the time is in terms of the ventricles. Okay, so we start with ventricular contraction. Before tani start, unsa may position sa mga valves? Before tani start to contract. The AV valves, kibaba mo sa AV valves, no? That's the mitral valve and the tricuspid valve. The AV valves are open. Kaya gikan man ta nag-feeling, di ba? Gikan man ta nag-feeling of blood. Siyempre, pag start contraction, open siya. And then, pag contract, we close. Okay. And then, pag close niya, close na po dayon tanang valves. So that's why it's isovolumetric. There is no change. So look at the volume here. There's no change in the volume. Okay. And then, there's isovolumetric, no change in the length of the ventricular muscles. Okay. So, of course, the pressure in the ventricle will markedly increase. Nag-contract kun siya, niya, wala ejection, wala removal of blood. So, na-increase kit kaayo ang pressure. That's why there is a very steep increase, rapid increase in the pressure of the ventricle. Unya, rapid kaayo niya, high na yung pressure, naka-overcome siya sa pressure in the aorta. Kaya kaning pressure sa aorta stays high. Di ba kanang imong blood pressure, kanang imong systolic, di ba kay ba mo, di ba when we report blood pressure, aortic pressure man and pressure in the large vessel. So, ang imong palitay imong blood pressure 120/80. So kanang imong 120 is systolic pressure. That is the pressure, highest pressure in the aorta. So, only highest pressure in the aorta, and that's about, at the average, in lang 120 millimeters mercury. And then, imong diastolic pressure, 120/80, and imong diastolic pressure, that is the lowest pressure during diastole. So, that is pressure at this one, just before, or even we can say here, just before the onset of ventricular contraction, or it will change pressure only when this will open. So this is now your diastolic pressure. So you see here, from systolic pressure of very high, 120 here, and then it slowly decreases to become your diastolic pressure. And it is now at about 80 millimeters mercury, okay? So here, the pressure of 80, diastolic pressure 80, the diastolic pressure of the aorta, which is 80 millimeters mercury, has to be overcome by your ventricular pressure. Your ventricular pressure has to overcome that. When it is now greater than aortic pressure, syempre, ang aortic valve will open. Okay, so the minute aortic valve opens, there is now ejection of blood into the aorta. So now blood is ejected into the aorta. And look at what happens. The volume in the ventricle will decrease because it's already ejected into the aorta. And because blood is already ejected into the aorta, syempre, aortic pressure will increase. Okay. So at about this time, ang imong blood entering the aorta, the pressure that is greater than, or the volume of blood entering is greater than the volume of blood that is going to the periphery, meaning going to the arteries, arterioles, to the tissues, to the systemic circulation. So pressure is greater, pressure in the aorta is still greater than your pressure in the aorta. That is because blood is flowing out of the aorta, and there will come a time that the blood that is flowing into the aorta and blood is flowing out of the aorta will be equal, and that will be the time that aortic pressure is at its peak. Mo peak siya diri. Now, your ventricular pressure during this time of rapid ejection is greater than aortic pressure. Muna nagsigi jud og there is flow of blood from the ventricle to the aorta. Okay. And then, mo peak ni sila. So, aortic pressure peaks now. Runoff, or the blood flow to the aorta is now equal to the runoff from the aorta. Okay. So, you have it there. That will now be the peak. That will now be the end of your reduced ejection phase. And the beginning of the, that is the end of the rapid ejection phase and the beginning of your reduced ejection phase. So peak ventricular pressure, peak aortic pressure. Kaning peak aortic pressure, mauni ang inyong systolic pressure sa inyong blood pressure. Na inyong i-take 120 over 80. Pwede po 160 over 90. So sa ato pang imong aortic pressure ni abot 160. Oh, so we're just taking the average normal, which is 120 lang atong i-represent. So, now, niabot na siya sa iyang peak, and then we are now at reduced ejection phase. So, gamay na lang ang blood nga gi-eject, and ventricular pressure is now lesser. Ano mawa man akong araw? So, ventricular pressure is now lesser than aortic pressure. But blood still flows from ventricle to the aorta because of momentum. Okay. And then, di ba, ang aortic pressure, daghapoy ejection, right? As shown from our volume curve. Okay. Na-decrease gapong volume. Sa ato pa, gi-eject gihapon to the aorta. Alright. Now, here, ventricular pressure is now less than aortic pressure, so that by towards the end of this phase, ang imong aortic pressure is now greater. So therefore, ang imong blood sa aorta will tend to go flow back, di ba? Mo retrograde flow. Kay less na good ang pressure sa ventricle. So murag siya gusto mo balik sa ventricle, but di siya kabalik sa ventricle kay mo sira naman dayon ang imong aortic valve. Ining ana dito sa dugo, mo retrograde flow, musira ang imong aortic valve. Okay. So some authors would say nga naadyo gamay nga blood ko nung moadto dito sa ventricle. Sige, inong tanan. But anyway, what is important there is that it causes the closure of your aortic valve. Okay. So now, aortic valve is closed. So at this time, at this time now, kay aortic valve is closed. Okay? So at this time now, closed na pod ang imuhang tanang valves. Di ba? Kay na-close man to diri. Na-close na to diri. So all the valves are closed, and therefore we have now the onset of relaxation of the ventricles, which we call relaxation. Kay in volume, kay ang tanang valves. Closed imong aortic valve, closed imong aortic valve, closed imong mitral valve. So apoy flow from the atrium to the ventricle. Kay closed imong mitral valve. So we call this now onset of relaxation. So this is the start of volumetric
Doc,
relaxation.
naputol
Putol-putol na sad. Okay, di masaktan.
Dapit sa during relaxation na Doc, dito nagputol-putol Doc.
O, sige. So, inigsira sa imong aortic valve, then that will now mark the onset of ventricular relaxation. Relax na siya. Wala mag-contract ang ventricle. Wala mag-contract ang ventricle. And then, mag-contract yung atrium. So, relax. So, therefore, ventricular pressure goes down rapidly. Equivalent there is a rise rapidly. Ngayon na po, go down rapidly, decrease rapidly after sa ventricle. Now, and we notice here in the atria, sige na siyang increase in pressure. Sige mo siyang accumulate of blood. Okay? Ang blood coming from the lungs, yung sige accumulate. So now, nag-increase. So you now have a wave until ang modern greater than ventricular pressure. Iba na dahil yung dakan. Ano kayo? Layo ang ventricular pressure. Ako ay pressure difference. Abot diri, ang atrial pressure, andiri na sa pag-open. Kaya during the isovolumetric relaxation, okay, pressure in the atrium is also now increasing, but kasi siya receive of blood from the periphery, and then the minute atrial pressure is greater than ventricular pressure, bisa mo yung kagamay ragid kay ang greater, yung pagka-greater gamay ragid kaayo nalan sila pareha, pero it's greater, no? So the minute atrial pressure becomes greater than ventricular, then the mitral will open. Diba? Munta open depends on pressure gradient. So the minute, yes. What mo?
Putol-putol ka daw.
Doc.
Hello, ni oy. Hindi na yan na. Masabtan man ka. Di yun masabtan?
Kuan ra Doc, nalay part or portion mo hinay ka rin, mobalik ra pud.
Pero masabtan man ka. Katong hinay portion, makakadungog man ka mo.
Maputuloy siya.
Well, anyway,
Sige, Doc.
tanaw na gid mo ang curve, ha? The minute atrial pressure is greater than ventricular pressure, o pressure difference, syempre, ma-open na gid ang imong mitral valve. Kay greater na gud ang pressure sa atrium kaysa ventricle, so ma-open. Inig-open sa imong mitral valve, magsugod na din, o fill ang imong ventricles. Diba? Open na gud imong mitral valve. So, ang imong dugo gikan sa atrium, mahog na gina sa ventricle. Alright, so the rapid filling gud na. So, you have already there, rapid filling, o tanawa din ang imong ventricular volume. Diba? Na-increase. Okay. And then, lisod pagsulti, when is this, and when is that, but anyway, ato nyo gibutang diha. And then, feeling continuous, dialysis feeling continuous, pero slow na feeling. There's still an increase in the volume in the ventricles. So, atrial pressure remains greater than ventricular pressure. And then, mo contract ang atrium mo contract. So, ni-increase ang pressure. You have now the A wave, meaning atrial contraction. And then you have now also the ventricles will also now increase in pressure. Marag mataba because as I said, during this time, mura sila one container, mura sila sa container. Kaya mura sila gasumpay. Unya, when the atrial contracts, ang increase in pressure sa atria, ma-reflected po dito sa ventricle. But still, atrial pressure is greater than ventricular pressure. So the amount of blood that is added to the ventricle because of atrial contraction is 20% of the cardiac output. So daghan-daghan pud oy. Okay, 20%. And then phase when ventricular contraction starts. So, kita dire, mo ni imong A wave, ventricular contraction, so ni contract, and immediately pod, very kuan lang gid kaayo, very short time, mo close na po dayon ang imong mitral valve. So, back na ta sa original. So, systole is from onset of isovolumetric contraction phase to the end of the reduced ejection phase or to the onset of isovolumetric relaxation phase. So from onset of isovolumetric contraction to onset of isovolumetric relaxation. And diastole is from onset of isovolumetric relaxation to the onset of ventricular contraction, isovolumetric. So cycle din na, isovolumetric contraction. So di ba nag-cycle na? Okay. And then, di mag-break na lang ko sa ta. Di pa kang point. Oh, doon naman questions before we take a break. Di, unsa may wa maklaro. Unsa man. Question B, before ta mag-break. Wala na? Klaro na? O, wala ko ninyo madunggi. Hello? Hello?
Nara.
Nara, yun. Naguba na gid ko. Sige, so mag-break tayo. 5 minutes? Enough na? 5 minutes? 10 minutes.
Thank you.
Sige, mag-break tayo. Ano may questions?
Basig Nara later, Doc.
Sige, basing nara later. Sige, basahan ninyo during the break or you can take your kidney break or you eat or whatever. So, sa man 10 minutes? Sige, 10 minutes. You review my lecture and you ask questions. So, proceed na ta. Okay. Pagbasa lang niya mo sa inyong notes o makainom doon na mo sa akong ipangyaw-yaw karon.
Tagaan kami ni Juan ito nga, kanina imong graph, Doc.
Ano mo, ana? I gave you slides, and then, kuan, kining, unsa ni? Tanawa ra good. Di ba? I gave you handout, slides, and the objectives. Tulo akong ihatag sa inyo. Okay. So, magpalata. Sounds. Okay, so, di ba, nag-laboratory naman mo aning heart sounds, right? And, tungod sa inyong lab, so you now know how to use the stethoscope. So, the position of the earpieces should be towards the front. All right. Now, when do you use the diaphragm and when do you use the bell? Di ba na, may diaphragm and bell. Okay, unsa man ang bell para unsa man na? Para na siya sa low frequency, muna bell, may L, bell, low frequency, okay? And the diaphragm, kaya naman siya H, diaphragm, sa high frequency, okay? And then I'm sure you already know the clinical valve areas, right? Familiar na mo aning ang drawing, di ba? Hello? Hello? Hello?
Yes, Doc. Yes, Doc.
Yes, Doc.
Oh, di ba katultol naman mo anino kaning asa ni kani aortic valve area, di ba mga clinical valve areas dili man gid sila found over the valves but where the heart sounds are heard best. Okay. Now, there are 4 heart sounds during the cardiac cycle. Okay. But we only usually just hear the 2 heart sounds. And kaning 2 heart sounds, you have the first heart sound and the second heart sound. Makain, di ba? Nakasuwan na ba mo paminaw heart sounds? You try to practice. Di ba? It will sound, the first heart sound will sound like love, then higher frequency, and the second heart sound dub. So love, dub, lobed up. So you will really know where is the first hard sound, the second hard sound, the next first hard sound, kay bawgid mo ana. Kay when you listen, lobed up, lobed up, lobed up. So you can really tell which one is the first hard sound and the second hard sound. And then they are heard best. So yung first hard sound, heard best as a man. This one here. And then the second hard sound is heard best in the aortic valve area. But of course, you hear the sounds good everywhere, but they are heard best ani mga valve, clinical valve areas. So let us study. Okay, now you have it there also in your asynchronous events in the left side and right side of the heart during the cardiac cycle. So may pasabot ng asynchronous events, meaning they are not actually exactly good. They do not really exactly occur at the same time. But the asynchrony is negligible. So dili kay ka-feel nga dili di gina sila nagdungan. But when there is disease, kaning asynchrony maklaro na. So that you have an idea now what's wrong with your heart, no? So if you I would like to go back, no, kani look at your, di ba nagdamog sa inyong notes, sa inyong handouts, naman ni dito. And then I will just like to show you the asynchrony of the heart. Okay, now I would like to go back to the previous slide. Okay, now what is asynchronous? Aortic valve contraction of the right atrium occurs earlier than in the left. Why? Diba? Right atrial contraction occurs earlier than the left atrial contraction. Why? Be? Na naman? Nung una mag-contract ang right atrium kaysa left. Why? Uy, di ba? Nag-review ko sa kuan, depolarization ganiha. Unsa may una ma-depolarize? Ang right or ang left?
Right. No.
Ang right. Why man unang pa-depolarize ang right?
Nahadara, Doc, ang SA node.
Okay, very good. Because the SA node is there. So, mag-unas good. Pero, dili na ito ma-feel. Asynchrony is negligible. It becomes significant only when there is disease. All right, so. And then another asynchrony is the onset of contraction of the left ventricle. Onset of contraction, this one, no? Diba? Onset of contraction of the left ventricle precedes that of the right, meaning it occurs earlier than the right ventricle. Why? Because the depolarization of the left is earlier. Why is it earlier? Because di ba ningin kung ganiha nga, ang left bundle branch block, ang iyang impulse conduction is faster. Di ba? So therefore, mag-una gid og ka-depolarize ang left, and therefore the contraction of the left will precede that of the right, and that is shown here in our diagram. Look. Kung mag-una og contract ang left ventricle, kinsa may maunag close, ang mitral valve o ang tricuspid valve? Kasabot mo sa akong question. Balik ha. Pag-abot diri sa isovolumetric contraction, iba, inig-start sa contract, musira dayon, ang ventricular pressure will increase immediately, closing the kanang mitral valve. So MC, mitral valve closure, ana. And of course, there's a right side. Unsa bay mo close sa right side in a ventricular contraction?
Tricuspid.
Tricuspid valve. Now, mitral valve closes earlier than the tricuspid valve. Why? So, MC is earlier, so mitral valve closure is earlier than tricuspid valve closure. Tanawa diri o, ang tricuspid valve diri nag-close, diri nga point. Ang sa kuan diri nga point, ang MC dinhi. So earlier gyud ang that's why I wanted this drawing, because I want to show you nga ang mitral valve closure occurs earlier than the tricuspid valve closure. Okay. And then the onset of ejection, kinsa may una nga mo eject, ang left heart o ang right ventricle? Ang left ventricle or ang right ventricle? Kanong sa man ang onset of ejection? Katong ni open ang imong aortic valve o sa right side ni open ang imong pulmonary valve. Now, which will open first? Ang aortic valve o ang pulmonary valve? Tanaw sa akong drone.
Aortic, no?
Kaning
Aortic.
PO. Oy, tanaw ha. PO is pulmonary valve opening. Di siya ni open diri. Diri.
Una, o do.
Ang imong aortic valve na open diri. Oh.
So,
So, unsa may unang ni open?
Asa ba?
Pulmonary valve open.
Pulmonary
First.
valve.
Wanong una man na siya? Oh, tanawa ra gud ang line ha. Ang imong aortic valve di ara siya ni open. Ang imong pulmonary valve ni open diri dapit wa kaabot sa line, di ba? Ni open siya sayo. Right?
Mm.
So pulmonary valve opening occurs earlier than the left than the aortic valve. Kaya ang gali ko, onset of contraction of the left ventricle precedes, onset of ejection of the right ventricle precedes that of the left ventricle. So kung nag-una og eject ang imong right ventricle, kay una man sa ni-open ang imong pulmonary valve. Di ba? Balik ha. Narin, di ba atong gidiscuss? Kaning lines nag-determine sa time sa left ventricle. Gidrawing na ko ang right ventricle, ang right side, because I want to show you nga dili gid sila dungan. And I want to show you kung kinsa nag-una o kinsa na-wait. Okay. Sa contraction sa ventricle, nag-una ang, sa may nag-una? Ang left, no? Nag-una ang left, kaya na-depolarize man siya first. Okay. Now, pag contract sa ventricle, pak sa kagmayo ang imong ventricular pressure until ni exceed siya sa aortic pressure o ni open ang imong aortic valve. Diri pod sa right side of the heart, ni saka dayon ang imong ventricular pressure o ni open dayon ang pulmonary valve. Look at the opening. Wa pa siya kaabot sa line, di ba? Ang line is left ventricular time. So, hay man nag-una, ang pulmonary valve opening or ang aortic valve opening?
Pulmonary.
Alright, pulmonary valve open first. Nga naman ni open man siya first. Naha, nag-ingon ta nga kuan. Onset of the contraction, tanawa sa inyong listahan, be. Onset of contraction of left ventricle precedes that of the right ventricle. So, nag-una og contract ang left ventricle. Okay. So, pag una og kuan, nag-una og close ang imong mitral valve, di ba? Ni unam siya close, nag-unam sa siya contract.
Yes.
So, una siya close. So, mitral valve closure is what na niyo? MC, mitral valve closure precedes TC. Tricuspid valve closure. Ibutang na sa inyong kuan. So, with the onset of contraction, nag-una ang left ventricular contraction, nag-una. So, therefore, kung nag-una ang contract ang left ventricle, this will make the mitral valve closure ahead of tricuspid valve closure. Di ba logical? Be, isink in sa kuno na ninyo, be.
Yes, Doc.
So, nag-una og contract ang imong left ventricle. So, therefore, nag-unam siya contract, nag-una og close ang mitral valve. Okay. Naiwit ang tricuspid valve. So, isuwat na ninyo, mitral valve closure earlier than tricuspid valve closure. Ang resulta ng onset of contraction of the left precedes that of the right. Okay. And then, the third asynchrony is onset of ejection of the right ventricle precedes that of the left ventricle. Nganong nag-una ha? Ang onset sa contraction sa left, nag-una. Pero ang onset of ejection, nag-una ang right And that can be shown because ang opening sa pulmonary valve occurs earlier than the aortic valve opening. O, isuwat na diya sa inyong inyong notes. So PO ahead of AO, pulmonary opening ahead of aortic opening. Pero ang akong question is, nganong nag-una man o eject ang right ventricle, nga nag-una man unta ang pag-contract. Diba? Ini-contract mo, eject. Pero nag-una ang contraction sa left and yet nag-una og eject ang right. Nga naman. So may explanation na. Ang proof nga nag-unang inject ang right because nag-una og open ang pulmonary valve. O late good ang aortic diri na. Ang pulmonary diri pa wa kaabot sa line. Kaya mang line. So naana. So nga naman nag-una mag inject ang imong ang imong right ventricle. Nag-una man siya og eject.
Doc, dili ka na siya tungod sa pressures, difference sa
Okay.
pressure. Mas
Oh,
taas
very good.
ang pressure sa aorta, mas ubos ang pressure going sa pulmonary circulation.
Oh, very good. So, dako kay trabaho ang imong left. Iyang dugay pa siya maka-overcome sa pressure sa aorta. Correct ay kadong. Kinsa man imong ngadong?
Akain, Doc.
Akain?
Yes, Doc.
Oh, sus, buotan jud kay ka. Kana kasabot jud kag physics ba? Right tingin kag physics sa una.
Sa una, Doc, 2000.
Sa una, karon mura na wala ka na bright. Sige, bright magyapon katubag man. Okay, very good. Onset of ejection of the right ventricle will occur first because gamay ra kay ang i-overcome nga pressure. Di ba? O, kagamay mo kay yung pressure i-overcome. Kari yung taon kataas sa pressure nga i-overcome. So mag-una gud siya ka-eject. Okay. Alright. Look at the fourth asynchrony. Completion of ejection of the left precedes that of the right. Oh, ngano naman, nag-una og eject pero naiwit og kahuman. So that can be shown sa aortic closure. O, narang aortic closure. Ang pulmonary closure, after na sa line, diara. Di ba, mo ni ang line nato sa aortic valve closure, mo ni ang line. Ang imong pulmonary valve closure, diara, after na sa line. So, ang imong completion of ejection, human ang ejection, faster sa left, pero nag-una biyag eject ang right. Pero nag-unang kahuman ang left. Ngano man, B? Ngano man. And that is shown nga ang imong aortic valve closure precedes pulmonary valve closure. Ngano mang nauna man siya kahuman nga naiwit man ta na siya sugod. Ngano man. Kay kuan man kaayo good. Oh, di ba strong kaayo ang contract? Oh yes, unsa man?
Di na tungod kay stronger ang contraction sa left kaya push siya blood throughout the whole body.
Okay, very good. Strong kaayo ang contraction sa imong left kasi imong right. So madali gid siya ka-eject. They are ejecting, remember they are ejecting the same amount of blood. Ang ilang volume of ejection is the same. Pero to eject that amount faster ang pag-eject sa imong left. Very good. So bear that in mind because now we go to the hard sounds. Kani ba? So unsa na nakasuwat na mo ana nga MC earlier than TC, PO earlier than AO, AC is earlier than PC. Nasuwat na ninyo? Sige, isubat ha. Alright. So, ang imo therefore systole is from, kung you're talking about valve closures, okay, ang imong systole is from MC to AC, right? Dili closure na ni dinhi. Kanina close, muna imong systole. Okay. And the other, from closure this one to closure this one, that will now be your diastole. Okay. So we now go to, do you have questions? We now go to heart sounds. Okay, you know already how to listen to heart sounds. Kaya nag-lab na mo, giinan ko ni Dr. Sevilla, nag-laboratory na daw mo sa heart sounds. Okay. Kanang, nakasaway na mo paminaw, dahil mo tayo lab good. Nakasaway na mo paminaw of heart sounds. You know, when you first listen to heart sounds, ala, ibutang ninyo ng stethoscope diha, agoy, daghan kay mo madungog nga noise outside. O maglisod og paminaw sa heart sound. So, what do you do? Focus. Ibutang ninyo yung utok, uy, maminaw sa kong heart sounds. I will ignore the sounds outside. So, focus lang gid na. Practice lang focus. Okay? Okay. So, that's how you listen to heart sounds. And then, di na ko mo review aning kuan ha, clinical valve areas. Kahibaw na mo ana, kay nag-lab na mo. So we now go to, okay, so now, nara. Kaning ni amo raguan sa inyong notes. Muna ni akong gipasuwat ninyo, okay? Okay, so now, okay, heart sounds. Kaningan lines, kana muna, S1 na siya, represent na siya S1. Kana siya represent S2. Then, layo kaayo pa, another S1 and another S2. Okay. Kaning S1 is due to, unsa man? Tanaw sa inyong notes. Is due to vibrations associated with the closure of mitral valve and tricuspid valve. Ini-close na nila, makakos sila vibrations. So, vibrations relating to or associated with the closure of the AV valves will cause S1. Now, what did we say? Mitral valve closure precedes tricuspid valve closure. That's why you go M1, T1. Mitral first, S1 na siya. So, mitral valve closure, T1. So, but di ka ka-hear anak nila. You hear only one sound. Diba? Naka-hear ba mo nag-separate na imong first heart sound? You hear it also only as one sound. Why? Because the distance sa imong M1, sa imong closure sa mitral valve o sa imong tricuspid valve, ang distance nila is less than 20 milliseconds. Less gali sa 20 milliseconds ang distance sa duha ka sounds, the human ear cannot anymore distinguish it as two sounds. The human ear will hear it as one sound. There. So M1, T1, and that will form the S1. Your first heart sound. Your second heart sound, nag-una o close ang aortic, di ba? So A2 precedes P2. And therefore, since the distance between the two sounds is less than 20 milliseconds, then you hear it as one sound. Okay. And then, okay, the next na. So, lub-dup, lub-dup. So, una na siya. You hear it like that. Lub-dup, lub-dup. Okay. So, pag-practice mo, oy, ano mo tayo lab? So, kamo na lang yung mag-practice. Kung doon na mo yung stethoscope, practice na yung mga manghod, yung mga silingan, o practice, paminaw sa heart sounds. So, ang first heart sound I have there in your notes, it is due to vibrations that is associated with the AV valve closure. And, okay, this is important. It clinically marks the beginning of systole. It clinically marks the onset or the beginning of systole. Why? Diba ang systole will start with ventricular contraction. Unya, it takes some split second nga usa pang close, diba? So ang closure really comes after a few milliseconds after the onset of ventricular contraction. Muna ningon na lang ko nimo. Clinically marks the beginning of systole. Kaya mo man ito madunggan. Inidungog din yung first heart sound. Kasulis inyong, nagsystole na. Okay. So it clinically marks the onset of systole. That's why we want to go clinically marks the onset of systole. Okay. And then ang location best heard, okay, ano na sa inyong notes. Unya, ang katong characteristics, naana po sa inyong notes. Okay. Then, kanang splitting. Kanang mo split na gali ng first heart sound nga makakita, makadungog namang, uy, di man one sound ra ako nadungog. Pero bright na gid kay kaana akong makadungog na gali ka nag-split ang first heart sound. Mula bright na gid kay kaanang listening. So mag-practice din mo. Practice din mo maayo. You know, you practice so that the minute you hear an abnormal sound, because naka-practice na kayo mo paminaw sa normal, makasense na din, uy, there's something wrong with that heart sound. So practice na lang mo daan karon so that inig ka-clerks ninyo dito naman sa hospital, bright na kayo mo paminaw, nya, kanang ang iyong residente dito, may danon sa man, so ingin na dyan, susdok, nag-split ang first heart sound. Wow, believe ang residente. Okay. So, ang splitting, usually splitting of the first heart sound is abnormal and it occurs in right bundle branch block, RBBB. Nga naman, kung mag-block ang right branch sa kuan, ang right branch sa bundle of His, nga naman nga mag-split man. And the splitting is due to ma-delayed ang T1, ma-delayed ang closure sa tricuspid valve. Ano man. So, mo na mag-split, kay ma-delayed man ni siya, mo far away naman ni siya, mo greater na ni siya sa 20 milliseconds. So, greater na siya sa 20 milliseconds. Okay? And then, why? Why man siya ma-delayed? Ma-delayed siya, why? Because ang imong depolarization, kay kuan man, na-block man tong imong right bundle branch no, na-block man. So, ang imong impulse will travel dito sa left bundle. And then, ang imong depolarization sa heart will be coming from diri na sa imong left ventricle by intercalated disc, cell to cell, ana. So, madili na gid kaayo ang imong depolarization sa imong left side of the heart. Muna ma-delayed ni siya. Kani normal ang iyang occurrence, but this one is delayed because the right side of the heart will take a longer time to depolarize. Ma-delayed yun. Kaya mag-depolarize usa dito sa left ventricle, usa mag-depolarize dito sa right. Okay. Then the second heart, any questions? Wala. Okay. Second heart sound is due to vibrations associated with the closure of the semilunar valves, the aortic valve and the pulmonary valve. Okay. And we already discussed earlier that aortic pressure closes earlier than pulmonary valve closure. So, muna siya. And this is best heard, so because the distance is less than 20 milliseconds, then you hear it as one sound. That's S2. And you have the characteristics there. And there is physiologic splitting. Look at the splitting. Physiologic, meaning it is not abnormal. But lisod sila ni paminaw, especially sa mga bago pang naminaw, dili ka ninyo ma-appreciate ang splitting of S2 during inspiration. And during inspiration, ma-delayed ng T2. Ma-delayed ang closure sa pulmonary valve. Why? Ini-inspire ninyo, udako inyong thoracic cage. Alright? Udako inyong thoracic cage, mal-decrease ang pressure dito sa intrathoracic cage, no? And then, ang imong blood vessels dito, ma-decrease ang pressure. So, ma-enhance ang venous return, ma-enhance ang flow of blood from the abdominal areas, then passing through the thoracic. So, ma-enhance. More blood will be going to the right side of the heart. So, na madugay o close ang imong pulmonary valve. Kaya daghan man siya i-eject. And daghan man ang venous return dito sa imong right side. Sige, di na lang tamo kanon ana ba? Libogon ana. Okay, sige, di na lang ako apil sa test. Kaning mga splitting. Pero, basta naana lang mo yung notes diha. Okay. And then the third heart sound, unsa man yung third heart sound? It is due to vibrations in the ventricles as blood rushes into the ventricle. and it coincides with the period of rapid ventricular filling. Kani bitawng third heart sound, no? Lalisunan di ani siya. Kailan di ang authors, lain sila. That just goes to show, wa pa sila magka-agree. And then, anyway, you will not be able to hear that. And is it normal? No, usually, kuan kuno ka ng mga children nga mga nipis kaayo chest wall kay mga niwang jud kaayo kanang muna maka-hear daw sila og third heart sound. Okay, kana requires na gid practice mga cardiologist ana maka-hear na gid sila third heart sound. Diha sa mga niwang o sa mga young adults usahay like adults like you and me, young adults, okay? So mag third heart sound ta. Okay, then you have the fourth heart sound. Okay, this is due to atrial contraction. Again, lisod din siya paminahon and usually it is just heard kanang kung by a phonocardiogram. Phonocardiograph. Kanang machine na siya nga mag-listen to, mag-record sa heart sounds. Okay, mauna siya. All right. Any questions about heart sounds? Tanawan na lang ninyo ang notes na ako kaya kompleto na siya. Questions? Okay. Okay, now cardiac murmurs. Kanang cardiac murmurs, kuha na siya. Kanang bitong mga hearts na nagmurmur kay gamay kuha sa test, wa katuon, kanang nahagbong mo na mga murmuring hearts, di ba? Ha? Mao ba na? Uy.
Nagyaw-yaw.
O, ka naman nagyaw-yaw ba? Kaya lisod kayong exam. Ana. Wa ko kasabot sa lecture ni Dr. Berdo. Nagyaw-yaw. Ana. Muna mga cardiac murmurs na sila sa mga students. Kaning cardiac murmurs sa medicine, mo ni sila. When you hear a murmur, kaning murmur, kaning abnormal sounds na murag noise na siya, kanang kadungog gali mo noise aside from the first and second heart sound, murag na yung noise, mo na siya gingalag murmur. When you hear a murmur, you have to characterize it. Because if you characterize it, somehow it will tell you asa gyud ang defect, asa gyud na valve ang nadepekto, asa gyud ang kuan kay. So you try to describe, you try to give the characteristics of the sound, the abnormal sound that you have heard. Okay. And then, okay, so usually it is due to daghang reasons diha akong gisulti sa iyong notes. And then you have to characterize it. Intensity. All right. Intensity, usually you grade it from grade 1 to 6. Okay, mura sa ning elementary grade. Kanang 1, murag hardly you ka-hear, ana. Kanang maglisod yung kag-hear, ana, especially if you are new to listening to heart sounds. Yung kanang sa grade 6 murmur mo na extremes, no? Kanang grade 6, grabe dyan na siya, makadungog ka, ana. Usahay, bisag wa stethoscope, makadungog na ka, ana, usahay. Oh, pero sobra na sag mayon kang nakadungog ka nga you are 1 kilometer away from the patient, nadunggan na nimo ang murmur, na sobra na sana siya. So, kanang very loud, you grade it no from 1 to 6. Okay. Uy, 6 ni kay grabe. Without my stethoscope, kadungog ko. Alright. And then ang pitch, imo sa siyang i-describe whether high pitch or low pitch. Okay, usually ang magamit ani is your diaphragm. Kailan mas diaphragm no? Sa inyong stethoscope no? Sa diaphragm, sa bell. Okay. This is best heard using your diaphragm. Unya, ang quality, okay, kaning quality, depende ni kanang descriptive terms din mo, it depende ni sa imong, I think it depends upon your vocabulary. Kay kanabitang makadungog mo niya, nindot kag vocabulary, which kag vocabulary, ma-describe din mo, makaiyong karong harsh, rough, rumbling, scratching, blowing, squeaky, maka-describe ka, or even makaingon ka, musical. O, di ba? So, depende na sa inyong kuan, sa rich sa inyong vocabulary nga ma-describe ninyo ang quality of the murmur. Ang duration, okay, duration, o mukaan sad mo between long, short, but ang duration somehow makatabang ning timing no kaning number 6 murag maka-timing na sa duration whether long or short or not. So when we go there, so ang radiation kada bang Asa mo gid siya na dunggan yung pinaka loud? Where did you hear it the loudest? Diin nga part sa chest was it loudest. And then you try to trace asa siya ni radiate, asa siya ni radiate, ni padung mo siya sa wala, ni padung siya sa taas, ni pasok boss, ni right, and inyo nang i-describe kung diin yun siya ni radiate. And that will be very helpful in your diagnosis of what valve is being abnormal. Kaya kaning timing of the cardiac cycle, okay, kani importante gid sa ni. Kaya you have to say whether the murmur is systolic or whether it is diastolic or whether it is continuous, meaning it begins with systole, ends with diastole. So, may kag systolic murmur if the murmur begins with or after S1 and it ends anywhere, no, before S2. So, it begins with or after S1 and it ends early, direct siya sa first part. So, you have early systolic murmur. So, direct siya sa first peak. So, sabi mo, lisod, di agad kayo siya. Holosystolic mean the entire system, whether it's early, mid, late, kaya mga na certain diseases nga ang description will be late, mid systolic murmur ni siya, bitaw. So maka later on when you deal with diseases, dinhi na ninyo ma-appreciate. Kani siya nga type of disease, cardiac disease, early ang iyang systolic murmur. Kani siya mid, So right now, just as enough for you to know nga na, you have to describe the murmur whether it's systolic or diastolic. But sometimes, pag-determine na lang din na systolic, makatabang na din siya. Pero makainom na early, mid, late, holo, hamon na din na pinakanindo. Okay. Then you can also say diastolic murmur because it begins with or after S2 and ends before S1. Again, you have to say it's early, mid, late, okay? So, muna na diastolic murmur. And then, continuous, mo nindot paminaon, kay di na dyan ka malibog, late ba, early ba, mid ba, kay mo begin gini siya sa systole, and mo continue hangtod yung diastole, mo nagpirmi na gid siya na sound. And mo ni imong madungog if you have patent ductus arteriosus. Okay? Meaning, imong ductus arteriosus, wala mo sira. Kay mo sira, manggitana ni kataw ni mo, but patent, it remains open. Muna, mag-rumble, makadungog kang continuous murmur. Okay. Any questions so far? Any questions? That will be your cardiac murmurs. Okay, now, kanang mga examples, no? Examples. Naman ko examples tingali diha, no? Di ba na ko examples? Pulmonary stenosis, so in systolic murmur, you have kanang mga examples, I have examples there. Now, haron dili mo mag-memorize in town ng some examples na ako itudlo ninyo. Try to recall unsay position of the valves during systole. Try to recall unsay position sa mga valves during diastole. Okay, now, moingon galitag cardiac or valvular stenosis, whether it's a aortic stenosis or aortic insufficiency, moingon gali kag stenosis, it means that the valve is not as open as it should be. Okay. Moingon gali kag insufficiency, the valve is not as closed as it should be. For example, kung pananglitan, that's why I told you, you should memorize, you should try to imagine the position of the valves during systole and during diastole. Okay, so systole. Unsa may valves nga open, unsa may valves nga closed. Okay, during systole, during ventricular contraction, unsa man valves ang open. Okay, tubag. During systole, unsa may open, nag-eject og blood. So unsa may mo open?
Sa may lunar valves, Doc?
Okay, the semilunar valves, di ba? They should be open. Di ba? Kay nag-eject ka. So, ang imong aortic valve should be open. Kay nag-eject ta og blood. Ang imong, what happens to your AV valve? It should be closed, di ba? During systole.
Yes, Doc.
Oy. Okay.
Yes,
So
Doc.
imagine,
Close ang AV valves.
oh, so during systole, the aortic valve and the pulmonary valve are open. Kaya nag-eject ko the blood. And the mitral valve and the tricuspid valve are closed para ang blood dili mo adto sa atria, right? Dito ra gyud sa aorta ug sa pulmonary artery. So mo na position sa
Yes.
valves during systole. Okay, now pananglitan. Na ay aortic stenosis. Unsa man ang murmur ana? Systolic gyud murmur, di ba? Kay it should be the aorta should be as open as it should be. Pero nag-stenosis man siya, meaning kanang stenotic ang lungag, meaning it's smaller. It's not as open as it should be. Yeah, during systole, kinahanglan open gid ang aorta. So, stenotic man, so mag-murmur gid na siya. Kay nag-agi sa blood through a stenotic valve, mag-vibrate gid na, mas kusog kay ang vibration, causing a murmur. Kasabot mo?
Yes, Doc. Yes, Doc.
Okay. So, mayroon ko ron. So, nang ayaw nag-memorize, anong, unsa galit yung mga kuan, mag-systolic murmur, kanang kuan. So, you should memorize the position of the valve. So, unsa may, so, diastolic. During diastole, unsa may open, unsa may closed.
AV valves ang open, Doc. Tapos sa may lunar valves ang closed.
May lunar.
Okay, very good. So, pananglitan, mangutana ko ron. Ang bibig kong example. Which of these valves will give a systolic murmur? Yan, may ngunday kong, nangatana kong systolic murmur. So, I will give choices. Ingon ko ron ka ng mitral stenosis. Sa man ang mitral stenosis, systolic murmur na o dili?
Mag-murmur gyapon, Doc.
Murmur no kay kanang mitral valve should be kanang wa man siya stenosis siya pero kanang di man siya sa systole dili man siya mag kuan og blood, di ba? Kanang close man na siya. Pero anos man na siya should be open. Ang imong mitral valve should be open during
systole, diastole.
diastole. Oh, tempa, ha. Balik. Okay, hasta ko nalibog. Okay, so, maingon ko ron. Kanang, I will give you a condition. Tell me whether it is systolic murmur or a diastolic murmur. Okay? So, mitral valve insufficiency. What will it give rise to? Systolic murmur, diastolic murmur? Saan man? Mitral insufficiency. Mitral insufficiency.
Systolic murmur po daw.
Systolic, diastolic.
Systolic po daw.
Systolic. Systolic, why?
Kay,
What is the,
during
what should be,
contraction, Doc, ma-open siya.
kung insufficient siya, sa pa di siya closed as it should be, no?
Oo.
And during systole, it should be closed, but it is not insufficient siya. So what will happen? In a contraction of blood, a small amount of blood will
Backflow.
go to the atrium, mo backflow dito sa atrium. So muna mag-cause of murmur. Right? Sagot mo? So systolic murmur siya, kay kinahanglan mo siya close during systole. Pero during diastole,
Wala siya problema, Doc.
wala siya problema.
Kay mo,
Kay-
problema siya.
Able man siya. Di man siya stenotic. So, able siya. Di lang siya kasirag maayo. Pero ang iyang opening is okay. So, wala yung murmur during kuan. Kanang diastole. Right? Sabot na mo.
Yes, Doc.
Oh,
Yes,
logic lang yun. So you don't have to memorize. Kani ako mag-give the examples, dahil na yung memorize sa. Sabta lang, di ba? So, magkuna-una, gid lang ikadihinoon mo. So, pero naalam mo kung ayaw pag-memorize ka, ay mga systolic murmurs no, kay mauni mo na. O, dili, kay sus, kakapag memorize, makalimot pa ta. So, understanding. Importante is understanding. So, dili na lisod. Giving examples, give examples of kanang diastolic murmur. Give din mag-examples. Kung mag-imagine na mo unsa may position sa valve sa during diastole, o maka-remember din ka nga, insufficient gali sa tupay, it's not as close as it should be. Now, what valve should be closed during diastole? Muna dayon. O, di ba? Sayon ra. Di ba? Sayon ra. Tando mo eh. Ako, gisayunan ko. Ambot ka mo.
Yes.
Ito. Kana, ramat trick.
Stenosis, Doc. Ang sagay ng stenosis,
Stenosis, it is not as open as it should be. Muna stenotic. So, stenotic ka, dili ka ka-open, inag-agis blood diya, so grabing vibration diya, makakos, grabing murmur. Abnormal murmur, abnormal sound na murmur na. So, panalitan be. Unsa man nga stenosis nga makakos og what valve should be stenotic na makakos og systolic murmur? Unsa man nga valve nga
Pulmonary.
Aortic stenosis and
okay, aortic stenosis and
pulmonary.
and pulmonary stenosis. Kaya di man sila open yun, and they should be open man unta, di ba? Kay one good systole, that is ejection, right? O, di ba? Sa yun ragid kayo sa tanawan niya exam, di ba? Makakuha gid mo ana siya aropod. Ana ra gunan. Ako
Bali,
basta
Ang insufficiency doc kay koan kanang if ever systolic murmur doc kay koan katong AV tapos ang
Which-
koan murmur doc kay katong koan cause ato niya kay katong semilunar valves.
sa may mga dili din ba?
Sorry, Doc, ba kay pwede man mag-stenosis ang semilunar o ang EV valves. Pwede po siya mag-insufficiency.
Pwede ko sila mag-sufficient. Ano? Pananglitan ron. Sa tayo mong question dahil, balik tayo mong question dahil. Okay, ato sila pa-answer. Sa tayo mong question, sila answer.
For example doc kay ang systolic murmur if cause niya kay insufficiency doc kay ang cause ato niya doc kay koan AV valve. Tapos,
Oh.
if systolic murmur, cause niya kay stenosis, ang cause ato niya, doc, kay koan, semilunar valve.
Let's be specific na lang, ayan na lang si Leonora, because conditions, musulti naman yung kuan ng aortic stenosis, pulmonary stenosis, so ayan na lang ng semilunar, specific. So, kung pananglitan, balik ha, during systole, kanang, di malas na ginang ang valve nga, stenotic pagod siya, insufficient pagod siya, di malas na ginang siya, no? So, mag-murmur na ginang siya, systole and diastole. Okay. So, pananglitan during systole, ang imong aortic valve should be open, di ba, during systole. Now, kung stenotic siya, mag-murmur ginang siya during systole. Pero during diastole, kani mga aortic valve, dili na siya makakos o murmur kay sufficient man siya. Ka-close man siya, di lang siya ka-open. Ka-close siya normally. Kaya di man siya insufficient, di ba? Ka-close man siya. Close man siya during, ano sa man ma-close ang imong aorta during
Diastole.
diastole. Okay. So, wala yung murmur during diastole coming from the aortic valve. Kay normal man iyang closure, ang iyalang opening, ang abnormal. Unang, iyang opening, stenotic man siya, so dili siya mag-murmur inig systole. During diastole, wherein that valve, the aortic valve, is closed, okay man iyang closure, dili man insufficient. Okay. So, walay wala aortic kuan murmur. Wala aortic valve murmur, wala, di ba? Kay sufficient man iyang valve. It is as close as it should be. So, wala, dili mo balik ang dugo. Dili mo balik dito sa, kung insufficient imong aortic valve, kung insufficient siya, and this should be closed during diastole, right? Aortic valve should be closed during diastole. Now, kung insufficient siya, sa ito pa di siya closed. Therefore, blood will go back from the aorta to the ventricle. So, mag-cause siya o murmur, diastolic murmur. Kasabot.
Yes, Doc. Thank you, Doc.
Okay. So, analyze na lang na dito sa inyong balay. Kung unsa, ang important dagiti, unsa may position sa valves during systole, unsa position during diastole. Now, kung ang iyang position should be that it should be open, unya di siya open, insufficient siya, di mag-murmur git siya. Diba? Again, be. Oh, unsa may murmur kung ang akong pulmonary valve is insufficient. Unsa may pulmonary valve is insufficient. Wait, tell me how you arrive at your answer. So, pulmonary valve insufficient. Unsa man ang murmur diha?
Diastolic.
Diastolic, why? Because during diastole, saan?
Pulmonary to, Dok ba? Pulmonary valve.
Pulmonary.
Ayun, insufficient siya, so meaning abri siya.
Oh, medyo wa siya masirag maayo.
Wala siya masirag-ayo.
Insufficient. Kano sa amin siya na magsira? Correct mo tayo answer, pero wa ka explain.
Diastolic murmur to, Dok.
Ha?
Diastolic murmur?
Ay, diastolic. Kaya kinanglan sirado mo na siya during diastole, right?
Oo, tama. Agi ko ng
Masirag maayo.
so naay mo lusot, naay mo lusot nga
Oh,
dugo.
naay mo lusot, oy. Naagi mo lusot. Oh. Okay. Sabot na. Okay. Kasabot na ta.
Yes po, Doc.
Oh, analyze na rong maayong gabi ha. Abi nimo di ay ang trick bitaw. Ingon sila ang kaning mga master in studying. If kaning first exposure nimo sa usa ka topic, like for example, karon pa mo nakadungog aning akong lecture, karon pa mo nakaana. So first exposure. Then you have to study my notes or your notes within 24 hours. Within 24 hours. So kinahanglan mag-study na gid mo ani rong gabi o di ba sa di pa mo buntag mag-study na mo kay ngano biyan nagali kuno sa 24 hours lost na to. Inig-study nimo kanang it's as if you are hearing it for the first time. Kay wala na kay recall. Maka-remember ka nga, uy, masa mo ito gisulti ni Dr. Verdon bahin ani, uy, nana ka. Pero although doon naman hinang mo yung notes, so dili kay lisod for you. Pero kung kamo lang nag-notes, di na mo, tanong kuno ninyo sa inyong notes, di na mo ka-remember, unsa ko ito gisulti ni Dr. Unsa ko ito yung meaning ani. Pero pag suwat ninyo ana, klaro kay ninyo ang meaning. Oh, pero pag after 24 hours, di na nagigailan ninyo klaro. So if first exposure ganin nyo ani nga topic, you have to study it within 24 hours. So kani nga itong i-discuss karon, study yun ninyo dayon. The first opportunity so that fresh pa sa inyong mind ang atong discussion o mas ma-recall na ninyo. Okay? And then, mag-second reading, bisa dili ninyo memoryahon, understanding lang ginusa. Kaya physiology ba, understanding ba ya? If you understand it, bisa tuwag-tuwaron ta mong question, maka-answer gid mo. Okay. Now, ang second dayon ninyong study is within 72 hours, second reading na giden mo. O mas earlier pa na, the better. Kaya pareha bito nang mag-countang, imong utok ba, first exposure, akong lecture, so naihanap ang line sa inyong utok. O within 24 hours, inyo na study, agoy mulaw-law din itong linya dito sa inyong utok. O mag-study na po din mo, mulawang pag itong linya sa inyong utok dito, o mas inyo na din niya, sa'yo na ang recall. Ano ang trick, ha? Pag-study na din mo karong gabi, o di ba karong hapon, na mo time sa akong notes. O di ba karong ikaw man yung paniud or what? O na yung trick diha. O, di ba? Labi pa sa physiology, nga understanding, and the minute you understand it, sa'yo, nagdi ka yung physio. Kung naganahan kong physio, good, favorite subject, yun din ako. Kay, makasabot lang ko, wala na, okay na. Sabton yun. Di kay kasabot. If you cannot, and the test whether nakasabot mo or wais, na ay tao, imaginary line in front, imaginary person in front of you. Explain na siya, explain ni, o kung sa imong gusto. Kana bitong mga murmurs, inana, asystolic, inana mo ni mo na, explain ni. Dili pagali ka ka-explain, sa ato pa, wa pa kakasabot. Kay sometimes, imong feeling nakasabot na ka. Pero, explain di ay mo to another person or to an imaginary person, yan di ka ka-explain, sa ato pa, wa pag yun di ay ni mo ma-master. There are times, abi ni mo, ay, clear na dyan ka ay nakasabot, sa lecture ni Dr. Burden, and then, ako na pa-explain, ikaw na pa-explain, wala di man di ka ka-explain, sa ato pa, wa pag yun di ka kakasabot. Klaro? So, mag-review na saan ka. Muna nga ako, advice niyo, study, gidain, ha? Kaya, ang physio sa yun, naging interesting, naging physio. So, matakdan, naging muna ako sa akong interest sa physio. Na, nindot, naging kaayo. Interesting ka yung physio. Okay, you don't memorize a lot of things, you just understand. Di ba? Hoy, tando mo. O, di ba, disagree mo? Hoy, tingog!
Yes, Doc.
Oh,
Yes, Doc. Thank you
Yes,
so much.
Doc.
Oh, so matakdan mo na ako, ha? Labi, yun na akong physio. First year, agad ko na in love. Pagka second year, physio lang ako kung dahan. Sa buwan na physio. Pero pato physio gyapon. Diseases ba yan? Mo start ba yung physiology, kung say normal. Oh. So, maayo kayong basic sa physio. Sa'yo na, pag-understand ka ng mga pathophysiology. Kaya there's something wrong with the physiology. So, mas tira ganin yung physio. Oh. See? Pero hinoon, kinalan gamay doon na ganyan anatomy po, anang alam mo, bitan start ko functional anatomy, kay di ko gusto mo discuss o function nga, wala may background, sa gamay na lang sa anatomy. Ang mga details anatomy, histo, dito na sa ilang subject, pero mga kung functional anatomy, just enough to be able to discuss function mo to, start ko to, just to be sure, nga doon na mo anatomy, kaya just ko tag-valves, kung kibaw kayo na dapit ang valves, ay goy, sus paita. Okay. One question na pa. Wala ha? Sige, next. Alright, regulation. Actually, ambot to na ba kay mo lecture good about cardiac regulation? Kaya kini manggod gidiscuss manggod ni dito sa inyong chapter. Sa chapter 9, gidiscuss manggod ni. So, ako na lang sa gi-appeal, pero di ko kay bagay mo kita sa papamanggod ko kakita sa inyong schedule. Doon na lagi lecture on cardiac regulation alone. So ako kay bagay. So ano lang ni kanang introduction. So we are not taking up all the regulatory mechanisms katulad na sa inyong libro ang akong i-take up. So intrinsic regulation is the Frank-Starling mechanism, or that is what you call the Starling's law of the heart. Sa amin pagpasabot na kag intrinsic, sa ito po, it's within the heart itself. So here, according to Starling's, within physiological limits, the greater the heart is stretched, the greater the force of contraction. And what will determine the stretching of the heart, kanang just before contraction, unsa na siya, how much within physiological limits, kay stretch na pod kaayo, na abnormal na siya, na dili na Frank-Starling mechanism. So within physiological limits, the greater the stretching of the heart, of the muscles, of the cardiac muscles, the greater the force of contraction. Why? So this is determined by your end diastolic volume, di ba? End diastolic volume, katong amount of blood in the heart just before it contracts. So kung daghan, mas stretch ang imong muscles. And pagka-stretch sa imong muscle fiber, you will expose more myosin. And also now your actin and myosin. So, ang pag-slide, there will be more myosin and hapin that will be sliding. So greater ang force of contraction. Munay kuan reason diha sa Starling's law of the heart or the Frank-Starling mechanism. So if your end diastolic volume is much, then greater ang end stretching, then the force of contraction will be greater and therefore your stroke volume will be greater. Okay, muna intrinsic kay naramagit sa heart sa imong muscle itself ang regulation. Now the rest, you have the nervous regulation, so your sympathetics. So sympathetic stimulation, okay, you have your nose there, usually sympathetic, kung ganyan siya, ganun, stimulation. So increase in heart rate, increase in force of contraction. While your parasympathetic is the opposite. Okay. Now the effect of inorganic ions, dili in ani pa ka-explain sa inyong libro, but this is how I got it from other sources. No? Hyperkalemia meaning high potassium levels. Hypokalemia, meaning it is low, no? So in hyperkalemia, there are two ways that will have an effect on the cardiac contraction. So increase in potassium level will cause depolarization of the plasma membrane. May mo siyang less negative. So ang imong, kung man less negative na siya, if you recall our potentials, ang imong sodium channels become inactivated, di ba? With depolarization, ma-inactivated. Ang tanan ng sodium channels, most sodium channels are inactivated. So, ang imong cell, dili na excitable. So, the heart will stop at diastole. Di na siya magsistole. Di na siya magsistole, right? Okay. So, munang hyperkalemia. Another mechanism for kani ko ana gini extreme na gid nga hyper, taas na gid ang imong level sa potassium ani. So, another is that kinidili lang ka ini taas. Hyperkalemia, syempre, taas man imong potassium, increase potassium efflux. Kanong sa gali mong potassium efflux sa inyong action potential? Unsa gali nga? Kuan? Phase?
Polarization phase, Doc.
Okay, the repolarization phase, di ba? Increase potassium. Kung mag-increase ang efflux, therefore, ma-accelerate yun ang imong repolarization, di ba? So, daghang kay manggawas ng potassium, madali gid ang iyang repolarization. So therefore, ma-shorten imong action potential. Meaning to say, ang imong action potential, ma-shorten katong imong plateau. And therefore, kanus aman musud ang calcium. Calcium will enter usually during the plateau wherein you have the L-type of calcium channel. So, di ba? So, ma-decrease ang iyahang entry, ma-shorten man ang imong plateau because nagdali siya repolarize. Nagdali siya repolarize, so ma-shorten ang imong action potential. So gamay ra ang musud nga calcium. So therefore, ang imong calcium gamay ra man, so therefore the force of contraction is decreased. So hinay ang imong beating sa imong heart sa hyperkalemia. Kung sobra kataas ang imong potassium, mauna nang di na gid magsistole. Diha na siya sa diastole, mamatay na siya sa diastole. Okay. Ang hypokalemia o hypo, less, mo decrease imong potassium efflux. So therefore, madungay ang imong plateau, ma-prolong imong action potential, ma-increase ang calcium entry, ma-increase imong force of contraction. Kadaghan ng calcium. Okay. All right. Then we go to calcium. I think calcium interesting na siya. So hypercalcemia, meaning increased calcium levels in the blood. Diba? Ang imong calcium sa heart, diba? Muagi pa dito sa L-type calcium channels na nasa T-tubule. Okay, taas ka imong calcium sa blood. Dili ka mo matter sa imong skeletal muscles, dili gini siya sa cardiac muscles. So increased calcium influx. Kaya daghang ko ang calcium, so daghang kay musud sa T-tubule, daghang muagi dito sa L-type calcium channels na nasa T-tubule. So therefore, calcium will be increased inside the cell, ma-increase yun yung force of contraction. Alright? And then, kung sige pag yun, taas pag yun imong calcium level, ang imong muscles will relax less and less. Kaya magsige siya contract until wala na yun. Di na yun siya ka-relax. Mag-permanente siya systole. Okay? O mo na naghanap, rigor mortis. Oh, mamatay na. In contraction. Ang systole, wala na siya ka-diastole. Kaya taas na yun iyang calcium. Now, kung hypo naman, but of course, the underlying level sa hypercalcemia, dili na inana. Kung gamay-gamay lang increase, so may increase lang imong force of contraction. Kaning akong giingong rigor mortis, kanina gid ang pinaka grabe nga hypercalcemia. So ang hypercalcemia naman is the opposite. Decreased calcium influx, of course, decrease po imong cross-bridge formation, decrease po the imong force of contraction. Logic. Kaning physiologic logic lang ba yagin mi po? Alright. Then, temperature, kaning temperature. Ayun na gid na. Kuan gali mo decrease imong temperature kanang tugnaw kaayo. So decrease pong imong sympathetic activity, ang imong pong heart rate mo decrease pod. Ug piughilantan pong ka na it will enhance ventricular contraction and bitanawa ko no, get your body temperature now nga wa kay hilante. Hilanta na gali kali pangusaka na 41. Tanawa niya imong heart rate ug ang imong ventricular contraction iba paspas. Force of contraction stronger. Kani pero grabe na jud ka extreme sa temperature below 25 niyo sa pagid na aywa na gid undang imong heart give up. Okay? All right. So that ends our lecture for today. Unless you have questions, B, from the beginning to now. Sa man yung question? We still have time. Asa man nga part ang inyong gusto? Okay na? Alright, now, wala ni question ha? In-lecture na ko, my next lecture will be murag November na on ECG. Now, inig-ECG na ko, you try to review kato akong lecture sa potentials. Okay, ha? Alright. So, wala na lectures, wala na questions, ano yung topic? Asam ba gusto mo balik? Sige na kayo. Because dapat may time. Wala na. Wala na gida. Wala na.
Thank you.
Okay, bye. Thank you, Sad.
Thank you, Doc. Salamat.
Thank you, Doc.
Bye-bye.
Nakasabot mo, pag-study lang mo sa iyong notes, ha?
Yes,
Thank you, Doc.
Within 24 hours.
Yes, Doc.
Okay, within 24 hours. Okay, you study within 24 hours. Anya, the sunida yun, the more ninyo na-repeat, the more yun ninyo ma-master. Maka-lecture na good mo sa inyong mga classmates. Okay.
Thank you, Doc.
Thank you, Doc.
Okay, bye-bye.
Thank you, Doc.
You are welcome. Everybody, you are welcome.
Thank
I hope
you, Doc.
nakasabot mo. Yes.
Yes, Doc.
You are welcome. Nakasabot mo ka mo. Oh, okay. Bye-bye. Saan ni pag-off day?
Yes, sana.
Wa may
Ang tab.
may tab. Wa tab diri. Wa may tab ana full screen man ni. Ay mo gi.
Escape.
Ay escape. Yeah.
So, i-open balik.
Can you stop sharing?